Welcome, everybody. I'm Melanie Béchard. I'm the current chair at Canadian Doctors for Medicare. And we're really honored to have all of you here with us for a really important discussion on the future of public healthcare in Canada. We've had so many conversations about the challenges facing the healthcare system that I think I speak for many of us when I say I'm really excited to speak about the solutions for once. Before we do get started, I would like to acknowledge that although we're meeting virtually tonight, the Canadian Doctors for Medicare office is located on the traditional territory of the Wendat, Anishinaabe, Haudenosaunee, Métis, and the Mississaugas of the Credit First Nation. Toronto is within the lands protected by the Dish with One Spoon Wampum Belt Agreement. The dish represents the land that is to be shared peacefully, and the spoon represents the individuals living on and using the resources of the land in a spirit of mutual cooperation. This agreement captures our responsibility not only to the land, but to each other as well, which I think is really relevant to the conversation we're having tonight. As you are all joining us from across this land, from sea to sea to sea, I encourage you to consider the traditional territories upon which you live and work and play. We must also recognize and underscore the significant and unjust health disparities that Indigenous people continue to face today in Canada due to systemic racism and the ongoing effects of colonialism. At Canadian Doctors for Medicare, we are committed to working to reduce these inequities as a key part of our work to advocate for better Medicare. Before we get started, there are a few key items to be aware of. This webinar is being recorded, so it can be shared with those who can't join us this evening, so please do take note of that. Please feel free to open the webinar chat and send messages to hosts, panelists. I would love to know where you're calling in from tonight and also what drew you to this webinar in particular. We'd love to have your comments and questions and personal experiences, making this evening all the richer. You can ask questions through the Q&A function at any time. We'll do our very best to get through all of them, but if there's a lot left over, we'll endeavor to create a list of answers that we will distribute over email. Closed captioning is available for this meeting, very helpful for fast talkers like myself, so please do feel free to turn it on. This event will run for approximately 75 minutes until 8:15 p.m. Eastern Time to ensure we have lots of time for questions, but of course, no worries if you need to leave on the hour. Thank you for sharing even a small part of your evening with us. So at this point in time, I will turn it over to my co-host and co-committee chair, Dr. Thara Kumar.
Thanks, Mel. Hi, everyone. Thank you so much for being with us here tonight. We're so happy to be sharing the space tonight with a virtual room full of people who are just as passionate about these issues as we are. I'll just give a very brief introduction to what this working group is and what work we've been doing over the last few months that's led up to this webinar. So today we're really diving deep into a pressing national concern. As you're all very aware, emergency departments across the country are grappling with huge wait times, lack of available beds, and even the possibility of having to turn away patients. At the same time, we know that many patients are waiting in very long queues, either for surgeries or for specialty consultants. I think we've all seen the effects of this either in our personal and family lives or in our work. I work as an emergency room physician in Alberta, and I certainly see every day people who are either getting worse with their clinical condition as they sit on wait lists, or who are presenting to the emergency department just unsure of where else they can go and how to access care. So this is a huge problem that we've all experienced. And as you know, at Canadian Doctors for Medicare, we're huge advocates of our publicly funded health system. But we know that people are desperate for solutions to this problem and desperate for answers. And so we want to be part of that solution. And we thought it would be a really good use of time to dive in a little bit to the literature and find out what are some evidence-based supported solutions that exist within the publicly funded health system for these wait time issues. And so we put a call out to our membership for some people who were interested in advocating and doing this deeper dive with us. And that's how this wonderful panel of people came together. Over the last few months, I've gotten to work alongside them, researching different initiatives and innovative health solutions that have been tried in Canada and all over the world. And today we're going to present to you kind of a small selection of those. So let me, without delay, introduce our panel here. So as I mentioned, I'm Thara Kumar. I'm one of the Emerge physicians in Red Deer, Alberta. We have here with us Dr. Henry Anand, Dr. Melanie Bishar that you just heard from, Dr. Bajayanta Mukhopadhyay, Dr. Devin Wilton, and Dr. Robert Winston. And a special shout out as well to Dr. Edward Z, who is another integral member of our working group but wasn't able to join us here tonight. So I will now share a little slide deck here and we'll dive right in. Each of us are going to present a few different topics to you, and then we'll be able to have lots of room for the most important part of this, which will be for some discussion. I think that's just loading up. And panelists, can you give me a thumbs up if you can see that? Okay, perfect. Thank you very much. All right, so these are some of the specific interventions that we've chosen to highlight in our webinar today. We're going to briefly talk about allied health pathways, overcapacity protocols, physician at triage models, e-consult models, ED observation units, centralized intake of referrals, and access to primary care. And I'll just preface this by saying this is by no means an exhaustive list of all of the different interventions that could be helpful. And not all of these will apply to every healthcare setting. Some of them are specific to specialty offices or to emergency departments, and some just might not be the right fit for every clinical practice setting. But we just wanted to give you sort of an overview of some of the options that we saw had the most interesting evidence behind them. So hopefully at least a few of these will resonate with you and might be a good fit for your practice setting. And with that, we'll take it away.
Hi everyone, I'm Baz. I'm a family doctor who works across Quebec, Ontario, and the Northwest Territories. Nice to be here tonight. I looked into allied health pathways. This was a pathway that interested me in the evidence. And so I'll give you a little bit of a description of what it might look like, and then look at some of the evidence to show that it works and what some challenges with it might be. So the evidence, the intervention is pretty self-explanatory. It's using allied health professionals and their expertise, such as audiologists, physiotherapists, occupational therapists, nurses, optometrists, to triage and provide initial treatment when patients are referred to specialists. So you might know of some of these initiatives already within healthcare systems. They're already quite present, but some of the evidence in the literature, for instance, have showed how they might reduce wait times for access to specialist care. A couple of studies in Ireland, for instance, one where physiotherapists assessed and provided first-line treatment for upper limb orthopedic issues. It was a great study. It showed wait time reduction. It showed more orthopedic surgery referrals, spots being open to patients who might actually need surgical intervention. Often physiotherapists would provide first-line treatments, and it resulted in patients being either receiving care and then being sent back to their general practitioner, or those who were assessed by the physiotherapist to certainly need surgical care being pushed on to seeing the orthopedic surgeon with with a little bit more of a triage in place. This particular study didn't assess wait times particularly, but it showed some degrees, a lot of concordance between what the physiotherapist and the surgeon would think were surgical cases and the rest being treated by physiotherapy right away. Another study in Ireland showed any hearing loss consult from the family doctor, from the general practitioner, going first to the audiologist, who did a little bit of triage, and that showed a clear reduction in wait times for access to hearing aids. That was one which really facilitated people's access to care quite quickly. And then there have been multiple studies in Ontario showing working with physiotherapists, particularly for rheumatology, and that showed a lot of reduction in wait times for appropriate referrals to see the rheumatologist. Some of the challenges with these pathways, one of the first ones is that these allied health pathways need to be funded by the public system, which can be a challenge in many provinces across Canada right now. So that's the first thing to actually make sure happens. But it also requires lots, maybe not necessarily lots, but some more training sometimes to do the triage and assessment from the allied health professionals. Um, and to remember that if you're talking particularly about surgical care, that there are two parts to a surgical wait time. One is assessment by the specialist, by the surgeon. So that's one part of the wait time. But then access to the operating room is actually a second part of the wait time, which this intervention may not necessarily address. And then the one thing to think about is people who aren't deemed to be particularly urgent or appropriate for specialist referral might see their wait times lengthen. Although I'm not sure if this is an actual valid concern because people are still being wrapped up or being um, brought into care with the allied health professional. There's a lot of reassurance, a lot of first line treatments, a lot of assessments that allied health professionals can provide. And so, especially for patients who might not need access to surgery, at least they're getting some care within a reasonable period of time. And so, might provide a response to some of the longer wait times to see the specialists themselves.
All right. Thanks very much, Batch. My name is Devin. I'm a first-year resident in emergency medicine at the University of Toronto. And I've been a member of the working group, and I took a look at overcapacity protocols. So overcapacity protocols are also called full capacity protocols in the literature, but they describe a group of, or I guess some policies that can look different at different sites, but the core idea is that when an emergency department reaches capacity and certain specific conditions are met, this policy is in place that requires the transfer of one or more admitted patients from the emergency department to the ward, regardless of bed availability. So they take direct aim at the issues of bed block in the emergency department, aiming to free up care spaces for new patients who are waiting to be seen, and to share the load of bed block throughout the hospital. So currently, in emergency departments where overcapacity protocols aren't in place, the idea that once the decision has been made to admit the patient, that they wait in the emergency department until a bed is available. This would sort of circumvent that in order to free up space first. They've been implemented in various Canadian contexts. So the largest in the literature that I could find is at Alberta Health Services, where in 2010, an overcapacity protocol was implemented regionally at 17 hospitals. The first in Canada that I identified was at Montreal's Jewish General Hospital, where one was implemented in addition to sort of a suite of other interventions to address ED wait times in 1992. And there's also evidence of implementation in Vancouver at Vancouver Coastal Health in 2006. If we go to the next slide, we'll look at just the example of the overcapacity protocol that was implemented in Alberta in 2010. So at 17 hospitals, 14 hospitals were tracked certain statistics in the pre and post implementation period. And this specific overcapacity protocol had the conditions that the emergency department had to have 10% more patients than funded care spaces exist, that over 30% of ED stretchers were blocked. For patients awaiting a referral decision or an inpatient bed, and had to have an arriving urgent or emergent patient, so a patient in the waiting room who needed urgent or emergent care, and without a space available. So once all those three conditions were met, the incoming patient was moved to a care space, and the most stable patient would be transferred to the ward on a no refusal basis. So the ward would have to accept the patient according to the policy. And you can see in these two charts here of these 14 sites that were studied, a reduction in overall ED length of stay for admitted patients at 14 sites, with the greatest reduction at the sites that are marked with an asterisk there. And those were the sites that prior to the intervention weren't meeting the province's goal of the overall ED lengths of stay of under 8 hours. So sites that already were dealing with like a significant amount of access block. And in the second graphic there, looking at just the number of patients boarded in the emerge at 10 a.m. on an average of 10 a.m. every day, also a significant reduction from pre-implementation to post-implementation. We'll go to the next slide. So there's a little bit of evidence in the literature about this. One systematic review that only identified 5 studies published in 2011 found that OCPs were promising, but overall that the evidence was limited. And then some individual studies of these instances in Alberta, the BC, and also a few sites in the United States that have shown that by and large, overcapacity protocols have reduced ED boarding time, reduced overall ED length of stay. And then looking at safety indications, the study in Alberta found there was a slight increase in ED revisits of 7.9% to 8.3% of people returning to the emergency department, but no increase in readmission. And a study in the States actually found that those patients who were transferred out of the emerge to like a hallway care space or to an urgent care, to a ward care space, had reduced mortality and reduced rates of transfer to ICU, suggesting actually a safety benefit for those patients who were moved. We can move to the next slide. Some challenges with the studying of these OCPs is that they look significantly variable in different places. So I mentioned this one example in Alberta Health Services, but other OCPs and other sites might have different triggers. For example, just having like all of the beds full and needing a patient to come in, and they can look different in different contexts. That also, though, adds to the flexibility when looking at implementing them in a new place. They can be kind of tailored to certain needs. And another sort of specific consideration is that this is an intervention where human factors play a significant role in contributing to either the success or failure. So since the implementation of something like this would need buy-in and consultation from not just the emergency department, but other inpatient departments in the hospital, one particular challenge is addressing sort of the perception of the problem of ED bed block, whether it's a problem that is just an emerge problem that emerge has to deal with, or whether it's really a problem that where the responsibility to address it is shared with all departments of the hospital. And so a credible project champion and real active advocacy for the implementation and the continued sort of success of the protocol is important here. Yeah, thanks very much.
Alrighty. So my name is Henry Ann, and I'm a pediatrician who is originally from Halifax, but I'm currently pursuing additional training in pediatric emergency medicine at the Hospital for Sick Children here in Toronto, and I'll be talking about physician at triage models. So just to give a bit of a background into how triaging works in Canada. So when a patient presents to an emergency department, they undergo triaging, which is typically done either by a single nurse or a nursing team. In Canada, we use CTAS, or the Canadian Triage and Acuity System, whereas a CTAS score of 1 is very acute and a CTAS score of 5 is the least acute. And what triaging does in the emergency department is that it allows us to see the sickest patients the soonest. Physician at triage models work by having a physician actually take part of that triaging process. And so whether they're actually joining the nurse, liaising with them, or in some models actually replacing them, the goal here is actually that some of that physician treatment management can start as soon as the patient arrives in the emergency department, and in most cases actually at triage. Next slide. So what does the evidence show? I've highlighted here 2 systematic reviews, which although have highlighted that the quality of the studies included have been mixed, they are pretty consistent in showing that physician triage models reduce a variety of ED performance measures, whether that's reducing the length of stay in the emergency department, or actually reducing the wait time for patients to see a doctor, as well as the length of stay has been highlighted in the second bullet there. Next slide. 2 of the hallmark studies for this model has actually occurred here in Canada. And so the first study was conducted in 2007 at the University of Alberta. And this was a randomized controlled trial which looked at actually having a physician at triage working with nursing, but also being able to start treatment, management, ordering tests, and even discharge patients if on their initial assessment they deemed that to be appropriate. And what this study showed was that the overall length of stay for patients who presented to the ED for that time period was reduced by 36 minutes. And the highest reduction was for CTAS-1 patients. And so those are the most acute patients, and that was a reduction of almost 1 hour. A second study conducted in 2013 at Sunnybrook Hospital here in Toronto also looked at a physician triage model, but this one was a little bit different. In this circumstance, patients would be triaged by the triage nurse. If there was a stretcher available, they would then go be assigned a stretcher and go into the emergency department. But when one wasn't available, they'd see a supplementary team that consisted of both a physician and a nurse. Again, they'd be able to start treatment, be able to start management, order tests. And again, if they deemed that from their assessment that the patient could be discharged home, they'd be able to do that there without the patient actually entering the emergency department. This study showed a reduction in the length of stay for non-consulted CTAS 2 to 3 patients, which I would say would be medium acuity, of about 24 minutes. But for the lowest acuity patients, CTAS 4 to 5, they saw, again, almost an hour reduction in terms of those that were discharged. And I put a note here that there was actually a significant reduction in the rate of patients who left without being seen. As we know, sometimes one of the consequences of ER overcrowding is that patients wait for hours to give up, and then they leave, which is not a good sign for any very efficient healthcare system. And so looking at this and the evidence supporting physician and triage models, I'd wondered, these studies were done in 2007, 2013. Why haven't these models been adopted more widely across Canadian emergency departments? And so if we go to the next slide, there's certainly a variety of reasons we can consider. But one of the things that we need to think about is what it actually means for staffing, and recognizing that physician at triage models are a catch-all term, and what that composition looks like and how it functions within an emergency department it can look differently depending on the institution. So whether, again, that is a physician physically at the triage, but has been pulled from taking care of patients in the emergency department, whether that's an additional physician staff, certainly you can think about how there might be some cost implications. And indeed, when studies have looked at the cost effectiveness of these models, the results have been quite mixed. And so a study looking at the cost effectiveness of the Sunnybrook model saw that there was some cost effectiveness at certain times of the day, whereas other studies that have looked at other models have really questioned whether really this is the most cost-effective way of doing this. I think it presents an opportunity for further research, especially in our current circumstance where we're seeing really high levels of ED overcrowding, especially post-pandemic, to reevaluate, given how effective these models seem to be, let's relook at that cost-effective question. And is this something that can be more widely adopted across the board? Thank you.
Greetings. My name is Robert Winston. I'm coming to you from the Patsi Kwantlen Simiamu territories, aka Surrey, BC. And I'd like to review briefly the impact of e and phone consults on wait times. Slide, please. How long are Canadians waiting for specialty surgical consults? Well, the short answer is too long. Next slide, please. An OECD review of 11 countries showed that Canada was on the bottom of the pile. And over a period from 2010 to 2016, it looked like we were getting worse. I hate to see that number now, but I don't suspect it's a lot better. Next slide. From 2014 to 2016, the average wait time was 78 days across the country and across all specialties. Of course, there's a lot of variability in that. Next slide, please. In British Columbia, a system called RACE, the acronyms just about killed me, but it was Rapid Access to Consultative Expertise, was begun in 2008 with a pilot study, and that was fully implemented in 2010 and showed widespread acceptance. The results of using RACE was 78% of calls were answered within 10 minutes, while patients were still in the doctor's office, which is pretty amazing. Next slide, please. RACE is a phone consultation service, and I think there is an app form of this. It allows care providers to have confidence in the care provided because you have contact with the consultant quickly. It resulted in 60% of patients avoiding a specialist visit, and it reduced hospital or ER visits by about a third. This system was developed, the primary actor, I think, was a nurse named Margot Wilson, and she's been with the RACE since the very beginning and continues to be active today. Next slide, please. The uptake in the community, different health authorities showed pretty rapid and consistent uptake across all health authorities. Next slide, please. The modified consult form has various acronyms, and it was begun in Ontario by Doctors Liddy and Keeley, and was called e-consult base service, begun in 2011. And the difference is that base or e-case allows inclusion of reports, labs, imaging, and EMR notes for the consultant to review. The RACE consult format was intended to get a response in less than 2 hours, although many return calls happen within 10 minutes and the patient's still in the office. BASE or e-case in BC has a 7-day turnaround time and reduce the need for face-to-face consults by 40%. BC RACE adopted BASE as a active consult form, and it was called e-case. Again, the acronyms are kind of painful. Next slide, please. Doctors Liddy and Keeley worked with a group of administrators called Connected Medicine, which acted to implement these consult services throughout the country, which was, I thought, a very ambitious ontaking, and did result in 8 provinces and 1 territory being achieving uptake of these services. As I did my research, I did notice kind of a monkey wrench in the system, and that was a CBC report. And next slide, please. And it showed that Nova Scotia has recently adopted a e-consult implementing a private investor-owned service. The report in CBC notes that the cost of this is $9 million over 5 years, and I may have those numbers wrong, but it was a fairly stunning cost for the province of Nova Scotia. Next slide, please. A summary of the benefits of either phone or electronic or app-based consult shows that it allows for rapid consults, reduces wait times, improves access for remote consults, reduces the number of in-person consults that are needed, which opens up space for appropriate in-person consults, and it provides a sense of support for care providers and allows care providers to be more engaged with the care of the patient. It reduced ED visits and reduced the cost to patients and healthcare system, time away from work, travel costs, and reduced facility use. So overall, I found it to be a very robust system to reduce wait times. Thanks.
Okay, hi guys. I've already introduced myself, but I'm next up to talk about ED observation units. So you may have heard of these by a variety of different names. They can be called ED observation units, acute medical units, short stay units, medical admission units. They go by a lot of names. But the basic idea of this intervention is that patients in emergency departments who are stable but need more time before they can be definitively dispositioned are offloaded into a separate medical unit called by ED observation unit or one of these other names. And so those units are taken off of the list of the general ER physicians and managed separately in an ED observation unit by either a nurse or a physician. So examples of patients who might fall into this category would be patients with chest pain who have already had a single negative troponin or are perhaps waiting serial troponins, patients who are receiving blood or electrolyte infusions that are expected to take several hours, or patients awaiting specialty imaging services such as MRI, which might take several hours as well. There's a lot of heterogeneity among models of this, so it can look quite different in different places. In some places, it's actually a physical part of the emergency department that's separate. In other places, it's a virtual unit, so it's just part of the standard emergency room, but certain patients will be labeled as being part of the ED observation list in whatever room they happen to be in. And so it's kind of fluid that way. Sometimes it's staffed by a physician, and that may be a physician dedicated to the ED observation unit or a physician who's fulfilling multiple roles, such as a physician at triage, for example, while also managing the ED observation unit. And in some places, it will be staffed by a nursing team. And there's a list of the many acronyms that will be part of this. The idea behind this is that the patients who are assigned to a CDU or an EDO are patients who are stable, and the remainder of their care is very much protocolized care. So these are patients who are often on a treatment protocol that's just anticipated to take some time, but the treatment protocol can be preset with automated discharge criteria, and so they don't really need an acute care physician continuing to manage them from that point. And then that will offload these patients from the ED physician workload so that they can spend their time seeing the new acute patients who need a workup initiated. So the evidence behind this, there was a pilot version of this that was done in the Ontario Ministry of Health and Long-Term Care. They piloted a project of clinical decision units, or CDUs, throughout Ontario Emerges in 2008. And I got to experience this a little bit when I was working at the Ottawa Hospital, which still has their CDU operating. And in a 2012 evaluation, they did find that the evaluation was somewhat limited by the small proportion of patients overall that were CDU patients in comparison to the patients that had come through the emerge departments. But within that limitation, they did note reduced ED length of stay, reduced admission rates to hospital, and they did not notice any increase in ED revisitation rate. So they didn't see any safety concern with this plan. There has been some international experience with these types of units, and the quality of evidence from international studies is a little bit mixed, but overall did tend to see the same things: reduced ED length of stay and reduced admission rates to hospital. Limitations of this are that the quality of evidence, particularly from international settings, is a little bit mixed, but has tended to see similar results. Like many of the interventions we talked about today, I think the success of this model is quite variable depending on the setup and the needs of a particular emerge department. And so the best likelihood of success would be if this model was really designed and tailored to the specific obstacles and resources of a department. So if you're looking at your own emergency department and you find that there's a large number of people who are getting MRIs, if you have a very active neurology consultation team and patients are coming to access those specialty services, then MRI patients might be one that could be a group that's quickly put onto a pathway like this and taken off of the general ED list. Similar for patient sites where you have a chest pain protocol that tends to take several hours. The other thing too to consider is staffing, whether you have a physician who could be attributed to the CDU without being pulled away from patient care, or if you have nursing staff available for this. So I think the real takeaway is just that this needs to be really specifically designed around the needs and the resources of any given department.
All right, thank you so much, Thara. So I don't think I actually mentioned, but I am a pediatric emergency doctor who practices in Ottawa. You will note that many of us do work in emergency departments, and thank you to Bob for corralling us and keeping us focused. But I'd like to start with a story. And this happened a couple weeks ago when I was working in the CHEO emergency department, and I had to refer a patient for an outpatient allergist. And just as I was opening up the chart to make the electronic referral, I look up, and on the wall right in front of me is a sign saying, "Notice, new pediatric allergist, short wait times." And I thought, amazing, this is fate. This is from the heavens. And I commented on this, and my colleague turns over and looks at me and says, "Mel, that sign's been there for a year." So I thought that there's this brand new allergist in town with short wait times. But that's because when it comes to physician referrals, we tend not to have a very organized system. Sometimes the system is as sophisticated as a piece of paper on an already very papered wall that you don't even notice for a year. Maybe that allergist has super short wait times. Maybe they're super long. There is no way for me as a referring provider to know, and there's no way for the patients to know. And this is where centralized intake come in. If we can go to the next slide, it describes it a little bit, but there's no need to read the slide. This is something that is intuitively familiar to all of us, whether or not you're a healthcare provider. Think of how you line up at a grocery store versus how you line up at the bank. At the grocery store, you line up for an individual cashier. Sometimes you get stuck behind somebody with 50 items and you know you're going to be there for a while, and you see people in the line next to you just flying by and you're looking over at them wistfully. At a bank, or most banks that I've been to, you would line up in a single line and everyone would go to the first available teller. And not only does this tend to be a little bit more fair, but it tends to even out wait times and actually lower them on average. So you're not getting these hugely prolonged waits that are bringing up the average wait time. And that's the concept of centralized intake. This is actually something that has been co-opted by Whole Foods and now other grocery stores. So you'll find more and more now that when you go to the grocery stores, you are having that common line and somebody's directing you to which line is available now. So it's proven in grocery, it's proven in healthcare, and it has some of the most robust evidence I've seen so far out of the solutions that we're looking into. So one study that was published in CMAJ Open, RIP, back in 2021, was a systematic review of 9 studies of various centralized intake systems in different countries, Canada, Australia, and England, and found that on average, just having these centralized intake systems were associated with a reduced wait time by 57% for referrals to surgeons and 40% for referrals to internal medicine specialists. So in this systematic review, which is a relatively high quality type of evidence, we saw that centralized intake systems could reduce wait times by about half. We've seen similar findings in other studies. There was a study looking at the Memorial University of Newfoundland's radiology department, and they found that having a centralized intake system reduced the time from having an abnormal scan to getting a biopsy about in half, from 61 to 36 days. And from abnormal imaging to actually getting treatment for likely cancer from 118 days to 80 days. Similarly, the Edmonton Bone and Joint Center implemented a centralized intake model and found that their overall wait times were reduced by 54 days. You can imagine reducing a wait time by 54 days can mean a world of difference to the patient. And what's more is that for patients who are the most urgent, the ones who had the most severe symptoms, the wait times were even further reduced by 86 days on average, suggesting that having these centralized intake models allows a centralized, more thorough, common, consistent triaging system that allows the most urgent patients to be seen first. And there's more evidence. The Edmonton Primary Care Network centralized intake system reduced wait times from primary care appointments to all consultants from 96 days to 73 days. Again, not as big of a magnitude of difference, but we're still moving in the right direction. And there is a centralized intake system for multiple groups in Saskatchewan that once again were found to reduce wait times by about 50%. So we're seeing various magnitudes of effect, but in the vast majority of studies looked at, we are seeing reduced wait times associated with this relatively simple way of reorganizing our referrals. There are some limitations and caveats to keep in mind. One is that centralized intake systems are often integrated with other interventions. By this point, you've probably realized that we're a little bit nerdy up here and we love our research evidence. And if you are someone like me who likes to look into biomedical research evidence and RCTs with excellent controls and placebos, when you look at health services research, you will inevitably be disappointed. Our real world is just too complex, and we're not able to control for other confounds as well as we can in the confines of an artificial controlled experiment. So all that to say, in a lot of these studies, the centralized intake was the main or sometimes only innovation that was being implemented, but it would often be coupled with other interventions, like reviewing your triage protocols or having a physician or nurse trained specifically to do the triaging. And it's really hard to tell, was it just the centralized intake that helped? Was it just this renewed attention and focus on wait times? Was it something to do with the triaging or a mix thereof? The other limitation, of course, is that you need buy-in. You cannot implement something like this and impose it on physicians, especially the way our health system is structured right now. Physicians often work as independent contractors, meaning that we're essentially working in our silos, and it's very hard to force physicians to do anything. And not saying that we necessarily should force physicians. This is something that should be co-created with the knowledge and input from frontline providers. But we do need to make sure that when these systems are created, that there is a way for physicians to opt in, to understand the systems and to gather their input on them. And of course, you need to have very clear and evidence-based triage guidelines. If you're not triaging appropriately, then you're just putting everyone in the same pool, but you're not necessarily picking out who has the highest needs. So last, but definitely not least, we wanted to cover access to primary care. And this is something that Edward looked into, our missing group member tonight. I should mention that there is a primary care working group at Canadian Doctors for Medicare. I'm going to cover this at an embarrassingly superficial level tonight because we had a whole working group looking into primary care. Because we truly believe at CDM, it is the foundation of a publicly funded healthcare system in Canada. However, we would be remiss if we didn't at least mention primary care in some ways it can help our health system to be the best it can be. So a lot of ED visits are avoidable, not urgent, or low acuity. If I had $1 for every patient who I saw in the emergency department who apologized for coming in saying, "I'm sorry, I couldn't see my family physician in time," I'd have many dollars. I can't tell you exactly how many. And this is, of course, no shame to the primary care providers who are often working very hard, often with very little support, who shouldn't be expected to see their patients 24/7, just as I'm not expected to work in the emergency department 24/7. But that's why we need to look at moving into more team-based models of care, both in terms of helping with staffing to ensure there is more consistent coverage, and also ensuring that we're having multidisciplinary teams so that family physicians aren't trying to be a jack of all trades and are able to truly do the work that's required of physicians and rely on the expertise of other healthcare professionals. When we look at other countries, there's many other European countries that fund true team-based models of care that are able to provide primary care services after hours and on weekends far more consistently than we do in Canada. We know that having these team-based models of care tends to result in fewer emergency department visits. And when we compare family practices where there's team-based models to non-team-based models, the rates of ED use actually increase less in team-based models over time. So even though ED visits overall are rising, they tend to be rising far more slowly when there's team-based models of care. So as an emergency provider, I love team-based models of care because it makes my job a lot easier. And as a patient, I love it too. And for my colleagues who work in family medicine, pretty much everyone I've spoken with wants to work in this kind of model. We do recognize that, as we've spoken about, a lot of the interventions to reduce emergency department wait times are not input interventions. They're not focusing on preventing patients from coming into the emergency department. We're focusing on throughput. How can we move people more efficiently through the emergency department? And output. How can we get people to their destinations, whether it's home or being admitted to a hospital bed, in a more efficient manner? So they're not waiting for 17, 18 hours, as some of the patients I was working with last night were waiting for a hospital bed. However, we can still see reductions in wait times if we are able to divert patients from the emergency department. We know in emergency medicine that there are patients who do present with low acuity conditions that wouldn't have needed to come to the emergency department. And this is not blaming patients. Patients do not always know where to go. We shouldn't expect people to recognize what's an emergency and what isn't, because that's why I went to 4 years of medical school and 6 years of residency to be able to pick that out. And a lot of the time, patients do want to find other options. Nobody wants to wait in the emergency department for 12 hours, but they just don't exist. So we have to look at other options for when people present to the emergency department for rapid or urgent care follow-up. One intervention that we've recently trialed at CHIO is a Kids Come First clinic. So if children present to our emergency department with a relatively low acuity complaint, they'll have the option of either seeing within the next couple hours or booking a same or next day appointment someone in our Kids Come First urgent care clinic, which is typically staffed by family doctors and some pediatricians. So that's a good way to divert some of our lower acuity patients from our emergency department, ensure our emergency department resources are safe for the kids who are most acute, and also, crucially, get patients and families home faster. Of course, there's a lot of limited quality of evidence of all of these studies. It's very rare to find a perfect health services RCT that you can hang your hat on, but we have to learn from the best evidence that we have available. And we want to be sure that we're not creating such amazing programs that people are not at all looking into other options and are using the emergency department as the first line for low acuity options to care. So we need to ensure that there's also equitable access for all. We all know that people are not able to access the emergency department equitably. There's geographic, cultural, language barriers. So if we're focusing on improving access to care to and through emergency departments, we're going to miss out on a lot of people who aren't able to get there in the first place. So just before we move into our discussion, I did want to provide some context and recognize that, yes, a lot of these interventions that we have lovingly researched and presented are very piecemeal. There's little bits of the puzzle here and there. But I did want to take a step back to have us look at the bigger picture. Because although each of these interventions can be individually helpful, you've heard that they all exist to some extent throughout Canada. None of these are entirely new. All of these have been trialed at some point. So why is our health system not fixed? Because we're all working in silos. And we spent so much time trying to make sure that we have the best possible hospital system or the best possible network within our town without looking broader and seeing how do we actually connect the silos into a true system that makes sense. So we need to look at the big picture, not just focusing on our own little parts, but seeing, okay, if centralized wait lists work well, why don't we implement these on a provincial level or territorial level? And it's been exciting to see that some provinces have been moving towards systems like that. We're not going to achieve the maximum effect of all these interventions if we do it here and there. It's a problem of scale. So we're hoping that by sharing this information with people from coast to coast to coast tonight, you can take this back to your communities, and hopefully we can work together and advocate to implement these interventions on a higher scale. And I do see that we have representatives from the Canadian Medical Association here today who are extremely well placed to take forward these recommendations and advocacy. So thank you very much for coming. At this point in time, I'll turn it back over to my co-host, Thara, for discussions and commentary.
Thank you, Mel, and thanks to all of our wonderful panelists for that great overview of these interventions. I think we've got some questions here trickling in, so I'm just going to have a look here. And in the meantime, too, if you don't have specific questions, please feel free to jump in with any thoughts you have. If your center that you work in has trialed some of these interventions and what your experience with them has been, we would love to hear that as well. I see one question here from Eric Hansen. Is the ER triaging model practiced in all provinces across Canada? I think you're referring to the physician at triage model with that. Please feel free to clarify if I've got that wrong. But I don't think that we found, and I'll let Henry speak into this, but I don't believe we found studies that were documenting this being tried in every province. As far as I know, it's not a consistently applied model, and there's many emerges that are not doing this yet. But Henry, I'm not sure if you found examples from most provinces or how widespread this was.
Yeah, thanks, Tara. I think if the question is specific to the physician and triage models, I would say that certainly not. I only found 2 Canadian examples, which would be the examples at Sunnybrook in Toronto and the University of Alberta. And I think even in those institutions, I don't know if they're still practicing this model. You recall that these were studies that were done in 2007 and 2013. So I think a natural sort of next step that I'm personally interested in is, what is the evidence not showing us? What are the reasons? What are the barriers? What are the challenges to implementing this model, or what were they, and what are the reasons that they haven't continued? I think if the question is talking specifically about the CTAS, so the Canadian Triage and Acuity Scale, I think that is standard across Canadian provinces across the country in terms of how triaging is done for patients who present to the emergency department. I can't say all. I don't know if every single emergency department in the country practices CTAS that way, but I think certainly across the country it's pretty standard. And if there are any institutions that aren't, they certainly would be in the very small minority.
Thanks, Henry. And yeah, I will say, I think a pretty significant barrier, especially for a lot of smaller hospitals with the ER physician at triage model, is simply a lack of available ER physicians. I know at the center where I work, we're desperate for physicians, and even just staffing our regular shift roster is quite challenging sometimes. So when we've looked at this model ourselves, there was just no ability to pull an extra physician away from our regular shifts in order to do this. And that's where some of those hybrid models that Henry had discussed, where maybe it is one of your regularly scheduled physicians who will duck out to triage periodically, or just be flagged by nursing staff to liaise with them and direct care of it, might be an alternative. But I suspect that is one of the big barriers, especially for smaller hospitals. We also have a comment here from Hannah Carolyn, and I'll just summarize essentially that there's some concern that she's seen that people are feeling overwhelmed in healthcare work settings, and particularly post-pandemic, and the concern that healthcare providers will start to think that privatization will improve things. And she says this is probably a known problem, but wanted to voice that. And thank you for doing that, Hannah. I think that is certainly something that we've all seen and experienced. And, I think a big part of the driving factor behind creating this working group was knowing that people are really desperate for solutions, both physicians and patients, and people are looking for any kind of way to reduce wait times. And I think in some ways there's been a bit of a public sentiment that if our current system isn't working, we just need to abandon it and move into other models, and particularly models that might be based in private sector or have components from the private sector. And that was a big part of where we at CDM wanted to say, well, it's not enough if we just keep saying everything should be done within the public system. We need to be specific and offer tangible solutions that exist within the public sector. And that was very much the inspiration for this working group and for this research. Mel, I see your hand up.
Yeah, thank you, Sarah. I have strong feelings about this, and thank you so much to Hannah for that astute comment. It is interesting, right? Because so many of us live and work only in Canada, and we only really experience the Canadian healthcare system, and it's very difficult to know what's going on. But all healthcare systems across the world have wait times. And all that I have seen have had increased wait times since the pandemic. So I can put some references into the chat. But since the pandemic, and this data were from 2022, so it's hard to say if it's better or worse now, but there were studies across the United States that found wait times increase for basically all medical professionals, anywhere from 7% increase to 48% increase. Even in Finland, which generally is seen as having a very strong healthcare system, surgical wait times increased by 30% during the pandemic as well. And this is not, of course, unique to the pandemic. We've seen every country in the world has wait times. There's no country in the world that has infinite resources to address everyone's needs immediately. So you have to decide how you want to triage your wait times. And sometimes countries will choose to triage based on ability to pay, and sometimes they can choose to triage based on highest medical need. And there's no perfect way. In a perfect world, we'd all get our treatment immediately. But the reality is that we're going to have to make some tough decisions sometimes because we don't have infinite resources, and we need to make sure that when possible, we're making them with the best medical evidence in mind. I think it's also important too that when we look at wait times data, we're not seeing patients who aren't seeking care at all because they can't afford it. So I don't have the reference to share, so I'm reluctant to share this stat, but I do remember attending a similar webinar and hearing that, I believe in the city of Dallas, about 90% of dermatologists refused to see patients who were on Medicare or Medicaid. So if you were on Medicare and Medicaid, the state-funded healthcare programs, and didn't have private insurance, your wait time to see a dermatologist would essentially be infinite. But in studies on wait times, that would count as 0, right? Because you're not even able to get to the point where you're waiting care. You're not even able to enter the queue. So I think that that's really important, is that having an accessible healthcare system allows people to enter the queue. So that might be partially why sometimes Canada comes out so badly in some of these wait times data.
Thanks for that, Mel. Any other comments from our panelists? Okay. I see another question that's come in. It says, I find the centralized referral system quite convincing. Perhaps we should try to focus on implementing these if there is good evidence. Is there good data on why we're in this crisis? It seems there's many reasons, and unless we understand why we're in this mess, our strategies may be misguided. That's an excellent question, and I think probably one with a complicated answer, and probably a bit of a different answer for every region of the country, every different type of center and different geographic location. But does anyone from the panel want to weigh in on that?
Go for it, Beth.
I mean, I think this panel knows what I'm going to say. So I work in Quebec, and I'm glad to see those other Quebec physicians in the chat, because I'd love to hear what your perspectives are as well. But Quebec made the shift to centralized referral systems for all specialties it's been gradually over the last few years. And I really, really love it. I find it simplifies my life as a family doctor, and I find it varies depending on the specialty, but certainly for many specialties, I find that the pathway of communication and access to care has simplified immensely, and in many times it's actually worked really, really well. And where I have concerns about a wait time, and this is a story from this week, I'd sent in an ENT referral in Montreal where there is an issue with access to ENT, and I put it in for like the 3-month wait list. Kind of, we prioritize it by chunks of time, and I put it into within 3 months, and it had been 9 months. And so I was just like, what's up? So I just emailed them, and within 24 hours, I got a response back from the centralized intake people saying, we're really sorry it's taken this long. We understand you're concerned. Just to let you know that this was dispatched to the clinic 2 weeks ago, and we're sorry. And it was just clear, and it was really, really helpful. But most times, I've actually found, not again, there's certain specialties like ophthalmology has always been an issue, but for things like general surgery, internal medicine, even in a system like Montreal, which is oversubscribed in many ways, there's not enough doctors for how many patients there are in Montreal. I found people get appointments in extremely reasonable timeframes. And if not, it's actually quite easy to sort out what's going on. I read in the chat that there was one concern about, well, what about if you have like hyper specialized, like, somebody's good at one particular thing. In the Quebec system, there's always you always can put in a nominative referral saying you fill out the centralized intake, and then you put in, I want this to go to this surgeon, and it gets put into that surgeon's queue. But what I find is for the vast majority of people, they don't need that hyper specialized care. They often need care, and so it's actually just a minority of cases where that's required. And I think the Quebec system has flexibility within it to allow for that. And just another plug, like we have moved into doing e-consults in Quebec as well, and I find that system has also worked really well. And it really just, you get response within a few days. It obviates the need for an actual in-person appointment. And me as a family doctor, I can just, if there's one thing I want to be sure of, I send the email to the consult gets back to me, and I just take care of it, and it's done, and it's super helpful.
I'll just add to that as well, Baj. Thank you for that response. With the question about kind of not all specialists necessarily having the same sub or subspecialties, most centralized intake processes that I've seen allow for the specialists who are part of that referral list to pre-select and qualify what types of consultations they can see. So if there's particular surgeries that they do or that they don't do, or particular specialties, for example, if it's a surgeon who does oncology procedures specifically, or a surgeon that does not do specific oncology procedures, then that can be flagged through the centralized system, and then referrals will be directed accordingly. So there is wiggle room for that. And then there's a question here that just came in about the question of why there are some places using this and why there isn't, and what are the barriers to centralizing the referral intakes. And in my experience with this, I think probably the biggest barrier is simply what Mel alluded to earlier, that everyone tends to work in silos. And so unless there is kind of a province-wide or territory-wide initiative to do this, it's not something that's easy to get up and running if you're a specialist operating your own clinic and not necessarily seeing what referrals are getting sent to your colleagues, even within the same city. I know I live in a relatively small city where our number of consultants in each specialty is often small, maybe 5 or 6. But even then, each of them has their own office, has their own medical office assistant receiving referrals. And even to get 5 or 6 specialists within a small city coordinated like this is not something that any one of them can get up and do. So it really does require, I think, more widespread information about this and sharing of the evidence to show that this works. And then buy-in from either groups of specialists locally within a region, or even more ideally at a province or territory level, to be able to coordinate this. And I know in Alberta, they've just very recently, within the last couple of years, implemented a version of this where all surgical referrals, for sure, I'm not sure if they've included any medical at this time, but surgical referrals are all going through a centralized intake province-wide. And that's been a big adjustment, but I think that level of change is really what needs to happen to make this more universal. One more question here in the chat, and I do notice some questions are coming into the webinar chat, which are kind of interspersed with just comments and discussion that we want to encourage. So if you have a specific question for the panel, please just put it into the Q&A, because it's easier for us to pick it out then. But I see a question saying, are the provincial governments placing enough emphasis on staffing and training positions from the university level and looking ahead to what the needs will be? I'll put that to our panel here. Thoughts?
Right.
Yeah, I see Henry.
Yeah, sure. No, thanks so much. And I think thanks so much for the question, Eric. And I think it highlights an area certainly of improvement for our country, and that is that of health human resource planning. I know Mel and I have been involved in work in the past, specifically looking at physician resource planning at a pan-Canadian level. And that has been identified as something that Canada doesn't do properly. In your question, you've asked specifically about provincial governments, and yes, there are tools and models that different provinces use. The actual models and how they do it vary across provinces, but they do try to predict, what kinds of physicians are needed in what areas, and use that to also determine the kinds of medical school spots, residency positions, and try to predict that in order to ensure that we are having enough physicians to support or to meet the population health needs. But what it doesn't necessarily take into account is that, physicians are free to move across provinces. I did my medical school in Halifax. Currently, I'm in Toronto doing my fellowship. Who knows where I'm going to work afterwards? And so that's sort of, again, speaking to Mel's point initially about siloing. It would be interesting and perhaps beneficial for us as a nation to just think about a more pan-Canadian approach to physician resource planning, but also not just for physicians, in terms of other allied healthcare professionals, nurses, respiratory therapists, paramedics. Do we know how many we need, where we need them, what kinds we need? And I think that's definitely an area that we don't do well, and certainly an area of improvement that I think is certainly would help solve or at least alleviate the crises that we're having currently in our healthcare system.
Thank you, Henry. And Baj, please go ahead.
Yeah, just on that front, and I think one thing about national pan-Canadian health and human resource planning is that there has been a discussion about pan-Canadian licensure for health professionals, particularly physicians, and maybe that's something to consider. But one thing that I do want to say is that in Quebec, there has been a push. I mean, I think it's been in a lot of provinces, but in Quebec, there's been a massive expansion in medical school classes. But what hasn't happened is the same sort of expansion for allied health, for like nursing students, for instance. And that, to me, a lot of the struggles within the healthcare system currently, yes, there are physician shortages, but there's much more acute nursing shortages, which working up north, I see. Like we have clinics in the remote Indigenous communities in northern Quebec that are barely functioning. With the one I work at, it's been working at, honestly, 20% of the nurses it usually works on. And so the fact that, it often attracts a lot of favorable media coverage to say, well, we're going to get more doctors, but doctors can't work without nurses, for instance, or physiotherapists, or you name it. And to have this sort of single professional approach to funding the system is not very helpful either.
Thank you, Baj. That's an excellent point. We're down to our last 8 minutes or so. So before I turn things back to Zarif, our wonderful team member here, to close things out, does anyone on the panel have any final comments they wanted to make?
I do see that there's a comment and a question in the chat about licensing of internationally trained physicians and healthcare providers. It's not an issue where CDM has like a clearly defined plan or policy. I think that there's a lot that goes into that for licensing and training and assessing and credentialing of healthcare providers. And frankly, our organization is just not an expert in that. And there's organizations that are. Personally, again, CDM doesn't have a position, but some personal thoughts being that it's such a shame if we have people who are willing to come and work in Canada's healthcare system who are not able to because of bureaucratic barriers when they can be contributing a lot of good. At the same time, I sometimes do think we need to think of our global community, and if Canada recruits very heavily and takes healthcare providers from other regions, that can worsen access to healthcare in other corners of the globe as well too. That also needs to be balanced with people's ability and willingness to be able to immigrate and move countries and seek different lives for themselves if they wish to. So I think it's a complex answer. I do think that obviously we shouldn't have people who are living in Canada eager to work in the healthcare field who are unable to, but I don't think our solution should be to try and solve our problems by poaching physicians from other places who need those services just as badly as we do. So it's a complex answer, but I think that there's a lot of really smart and caring people who are working on the issue, and hopefully it's something that can improve over time.
Thanks for that, Mel. I do see that there's a few questions that came in through the chat that might have gotten a bit buried in the other comments. So I apologize if we didn't notice one of your questions, but we are going to go through the chat. And if there's any questions that we didn't address, we'll pull those out. And as Mel said at the beginning, we'll try to put together a little follow-up to answer any outstanding questions. But for now, I will turn things back to Zarif to close us out.
Thanks so much, Tara. Thank you to all for joining us tonight and for such an engaging conversation. The chat has been so lively. It's been great to see. This is an issue that's definitely constraining our healthcare system. And a big shout out to our panelists for not only participating tonight, but also understanding these issues and walking us through it. Once again, if you're not a member yet, and if you're a physician, practicing or retired, medical school student, or a trainee, we'd love for you to become a member today. With that said, that more or less concludes our webinar for today. Please stay tuned for follow-ups. Thank you again.
Thank you so much, everyone, for being with us here tonight. And I will again just wrap up by saying that these conversations are so critical. This discussion has been so interesting. And even for us who, this is so much of what we live and breathe, I think it was still so fascinating to actually go through this deep dive and get to review what's out there and see examples of what innovative things people are trying all over the country. It's a challenging time to work in healthcare. There's been lots of comments about frustration and burnout, but I think we all feel really heartened when we see what incredible work people are doing all over the country at all kinds of different scales to try to make things better for our workplace, for our patients, and for health outcomes. There's lots of hope. There's lots of really wonderful work happening. And we would love to hear more of that. So if you're up to something interesting at your center or have questions, please get in touch with us. We'd love to connect with you. We'd love to connect you with the rest of our membership. And we'd love to have your expertise. So thank you so much again for being with us tonight, and have a wonderful rest of your evening.